Hi, our next speaker is Dr. Raksha Jain. Dr. Jain is an associate professor of pulmonary and critical care medicine and director of the Adult CF Care Center at the University of Texas Southwestern in Dallas. She's also co-director of the Site Therapeutics Development Network program. She's been an adult pulmonologist, intensivist, and researcher in the field of CF for nearly 15 years. Her main areas of research revolve around women's health, health disparities, and sexual and reproductive health. We welcome Dr. Jain, who will present reproduction health in men and women with CF. What do we know and what do we need to know? Dr. Jain?
Thank you so much, Jim. And I'd like to thank Siri and all the organizers of the CFRI conference. This has been an amazing conference and I've really learned so much this weekend. And I'm very much honored to be here and really talk about reproductive health in men and women with CF. For those of you who watched Dr. Euler's talk earlier today, I think he did a terrific job of outlining the multi-organ nature of cystic fibrosis. And I think this topic on reproductive health has really been on the back burner for many years. And I think it's now that people are living longer and healthier and better lives that we can really focus on some of these topics that really impact the quality of people with CF. So I'm going to start by really highlighting what I'm going to talk about today, and that is four main subjects, including sex hormones, fertility, contraception, and pregnancy in CF. And importantly, I'm going to really put these topics in the context of CFTR modulator therapy. As I think you've heard a lot about this weekend, there are four main CFTR modulators approved in the United States, and I'm going to spend a fair bit of time particularly focusing on what we call highly effective CFTR modulators, those who've had the biggest impact on the health of people with CF, and that includes ivacaftor, known as Kalydeco, and elexacaftor, tezacaftor, ivacaftor, known as Trikafta. So to start with sex hormones, it's important to understand sex hormones first in females with CF. And very importantly, levels of sex hormones in women with CF, and this includes estrogen and progesterone, are really thought to be relatively normal when you compare them with the general population. They fluctuate and cycle as would be expected throughout menses and ovulation, as long as women are appropriately nourished. Now, this is key, and we're learning much more about this as we've overcome a lot of the malnutrition issues in CF. But when you look at the population of an appropriate nourished status, we see that those hormone levels are quite normal. In addition, there's been some emerging data over the past several years that are trying to understand the impact of these hormones in the context of CF. And there was a very nice paper that was published in the New England Journal about 9 years ago from a group in Ireland. And they actually showed, if you look here on the right-hand side of the screen, that these blue bars are levels of estrogen throughout the ovulatory cycle. And this red dotted line is number of exacerbations noted in these women throughout the ovulatory cycle. And they really found this interesting association where when estrogen levels are high, there was an increased number of exacerbations. They further described in their paper that when women were started or took hormone contraceptive therapy, that this suppressed the endogenous cycling of sex hormones and were associated with a decrease in these pulmonary exacerbations. This work is ongoing, and there's actually a group out of the University of Washington in Seattle, Emily Godfrey and Moira Aiken, that are currently working on a study to further understand this topic. When you look at sex hormones in males with CF, this is a little bit of a different story, and it's actually been thought that testosterone, the main hormone in males with CF, might be potentially low in adult males. These testosterone measurements, very importantly, should be done in the morning and not during an acute illness. And in cross-sectional studies of young men with CF, approximately 25% have been shown to have low levels of testosterone. In another study, testosterone levels were described to be 2 standard deviations below baseline of those of healthy adolescent males with CF, in healthy adolescent males with CF. And when you look at the types of testosterone levels that are measured, there's total testosterone and there's free testosterone. And you may see this in your lab work that your physicians do. And these are very different, but both quite important to follow. The free testosterone represents a pretty small proportion of the overall testosterone, but it's the free and part of this testosterone that is bound to proteins that make up the part that is really important in what actually results in symptoms in men who have low testosterone levels. So when you further look at this topic of hypogonadism in males with CF, and hypogonadism is the reduction or the absence of secretion or activity of the gonads that results in this low testosterone, you can see that some of the symptoms that can result from this are decreased sexual activity or desire, loss of muscle mass, loss of energy and reduction in strength, some sleep problems, loss of emotional instability, and a number of other things that really can be quite vague. And so it can be challenging to understand when should we check these levels and when shouldn't we. And I'll tell you, in our clinic, we tend to screen most of our adult males at least once yearly because these symptoms can be so vague and different amongst different men. Testosterone therapy, if someone is low and you're going to supplement them or replace their testosterone, it's also very important to counsel men that this therapy or replacement can diminish spermatogenesis or the production of sperm and can adversely impact that person's reproductive potential. So this is a very important conversation to have if you are going to think about replacing these testosterone levels. So moving a little bit into fertility in females with CF, it's important to understand that the anatomy in females with CF is the exact same as the anatomy in females without CF. Yet we do see that there is some infertility that can occur. Now, the frequency of this is fortunately quite low, but we really don't know the exact numbers because fertility has not been systematically studied in cystic fibrosis. There's been a few reports, including one that gave the statistic that 35% of women may be infertile in CF. And this is higher than what's reported in the general population of about 25%. But we really don't have confirmation of these numbers because fertility is not something we capture in large registries or databases. So it's a challenge to know. It's also been reported that 85% of women with CF who do try to have a baby or conceive are actually able to within 12 months of stopping their contraception. And finally, it's also nice to know in some ways that 25 to 49% of pregnancies were unplanned. So this is important to recognize that infertility is not universal, and that women must plan for this because there are still quite a high number of unplanned pregnancies. And when you compare this with the general population, the numbers are actually fairly similar, about 45% rate in the general population. Now, to understand this potential infertility in women with CF, you have to understand a little bit about CFTR expression in the reproductive tract. And if you look at the main organs in the reproductive tract of someone with CF, the expression of CFTR in the cervical epithelium, that cervix, is actually very, very high. And this can result, and often does result, in the mucus, in the cervical mucus being very thick, viscous, and dehydrated. It also results in the cervix not thinning well, which is part of the process of what occurs when someone's pregnant. So these two processes can make it a challenge for a woman to get pregnant. When you look at the uterus, there's moderate expression of CFTR, and this CFTR in the uterus actually plays a key role in regulating uterine fluid volume. When you look at the fallopian tubes, which are the tract between the egg and the uterus, they're lined by ciliated epithelial cells. There's also moderate expression of CFTR here, and this can result in challenges of the egg getting from the ovaries to the uterus. And finally, when you look at the ovaries themselves, there's very little to no CFTR expression in the ovaries. Unfortunately, this means that the production of eggs is thought to be quite normal in a woman who has cystic fibrosis. So what does this mean in terms of the etiologies of infertility in women with CF? Well, first of all, as I mentioned, some of the etiologies can be amenorrhea, which is not having normal cycles, or altered ovulation, and much of this is typically due to malnutrition or health instability, etc. When you're in a good state of health and things are in ovulation and menstrual cycles have been normal, there's still a potential for infertility. And this is often because of those thickened cervical secretions I described. So if you look at this picture on the right, these secretions can be quite thick, and this is not typical. they also can actually plug the cervix and really not allow for passage of the sperm into the uterus where it needs to get in order to fertilize the egg. There's also the impact of CFTR on bicarbonate, that actually in the uterus in the general population, there's actually a high amount of bicarbonate. And this environment is therefore what we call alkaline, meaning the pH is on the high side. And that high pH allows for when sperm enters the uterus to go through a process that's called capacitation. And it's the process of the sperm to make changes in order to fertilize this egg. And when the pH is lower, as is often seen in CF as a result of some of the impacts of CFTR, that capacitation process is much more challenging and again, makes it difficult for the sperm to fertilize the egg, even when it's able to get into the uterus. So what do we know about the effects of CFTR on female fertility? Well, there is some thought and hope that highly effective modulator therapy may increase fertility and improve as it improves the general health and nutrition of people with CF. In addition, it's actually thought that it could potentially decrease the cervical mucus thickness or tenacity and increase the pH in the uterus, as I described, to make the environment much more conducive to sperm getting through the cervix and into the uterus to fertilize the egg. In a few studies, and actually one published here, depicted here on the right, that was published in the Journal of Cystic Fibrosis a few years ago, women were looked at in using the CF Foundation's registry to just track the pregnancies in women over time in the context of some of the phase 3 clinical trials that came out related to CFTR modulators. And if you see I'll just point out the green line that shows some of the ivacaftor trials that were done for those who had the G551D responsive mutation. And you can see that after this trial was over, there was actually a 2% increase in women with CF who became pregnant in those with this particular mutation, giving a trend at least towards an increase in pregnancy rate and potentially fertility after the initiation of ivacaftor. There's also been a number of case reports of unintended pregnancies in women who were treated with ivacaftor. And in addition, there's a report or a survey of 7 mothers with CF, 7 of whom reported that they were previously told they were infertile, and after being started on ivacaftor, were able to become pregnant. So overall, I would say good news that there might be some potential for highly effective modulator therapy to improve fertility in women. In addition, I'll share with you a case report actually of a woman from our center that allowed us to publish these findings in a recent report that was published in the Journal of Personalized Medicine by myself and Dr. Jennifer Taylor-Kauser, where this was a woman who was 31 years old. She was in quite good health with an FEV1 in the 80% range and a BMI of 22. And she had been told that she'd been unable to get pregnant for 2 years. When seen by an OB-GYN, they actually did an exam and a hysteroscopy where they looked in the cervix and uterus and actually found what you see in this picture on the left-hand side here of these very thick mucus bands and thick secretions. And the OB-GYN really thought that she was not going to be able to get pregnant with this thick amount of mucus that existed. She, at that time, in the middle of all this, actually became eligible for ivacaftor and was therefore started on ivacaftor therapy. After starting, she really described what she termed a vaginal purge. I think many have described the respiratory purge after highly effective modulators, but she had a vaginal purge where she had a huge amount of mucus that came out of her cervix, and those thick secretions she noted to become thinner. She actually ended up having a follow-up hysteroscopy exam with her OB-GYN, and you can see the picture here on the right where that thickened mucus had nearly completely cleared. Now, she has not yet had a child for a number of different reasons, but I think the OB-GYN is now encouraging her that she very much might be able to. So again, I think this is terrific news for some women with CF who wanted to get pregnant and potentially struggled. So when you look at for those women who do still have challenges with fertility, what are the options for them in terms of reproductive technology to conceive? And there's really 2 main options that are described. One is in vitro fertilization, and the other is intrauterine insemination. So if you can see on this picture on the right-hand side, what happens with in vitro fertilization is the woman will undergo ovarian stimulation here in order for the eggs to be produced at a high rate. They are retrieved directly out of the ovaries and harvested. They're then put in a petri dish with sperm that have been extracted from the partner, allowed to fertilize in vitro, again in a petri dish, and then the resultant embryo is placed back in the uterus of this woman to implant and then potentially carry out a full pregnancy and delivery. Now, these have some benefits and risks. Amongst the benefits, these embryos can actually be frozen for a later time, so they don't have to be used right away. The timing can be planned in a very nice manner based on health and other circumstances. It actually allows for potential pre-implantation genetic testing if someone's interested in that. And the success rate of this tends to be about 20 to 40%, which is pretty good overall. There's also the other option of intrauterine insemination. And this is where the sperm from the partner is essentially inserted past the cervix and into the uterus to fertilize directly in the uterus of that woman. And the nice things about this are that this actually requires no hormone stimulation from this woman, potentially, just the appropriate timing of when the egg is going to be in the uterus. There can be an associated risk of infections with this catheter going into the uterus to place the sperm. And the success rates here are a little bit lower, more on the order of 5 to 25%. But still, both of these are very viable options for a woman who's still struggling with fertility and CF and would like to conceive. And there are plenty of other options for motherhood for women with CF, including adoption and surrogacy and other options where the woman does not have to conceive or actually be pregnant herself. So moving into fertility in men with CF, it's important to understand that about 95 to 98% of men with CF are infertile. And why that is it's really due to what we call congenital bilateral absence of the vas deferens. And when you look at the picture here to the right, the vas deferens is this blue tube that essentially goes from the testes all the way here to the prostate. And that tube is missing in many men who have cystic fibrosis. As a result, the men do produce very normal sperm, but the sperm do not have the path or the tract to get out in the natural manner that would be expected. How do you diagnose this? I think a number of men ask that. And I would definitely recommend talk to your care providers, and many of them can run these tests or refer you to a urologist in order to have the test run. But there's three main ways. One can be with a physical exam, where the vas deferens in some men can be palpable. Now, it can often be missed, and so this is not always a reliable way to make this diagnosis. There's also a semen analysis, which is a very helpful and very sensitive way to make this diagnosis. And this is where the man would provide an actual semen sample, and this can be tested for the amount of sperm in the semen sample. And then finally, there's scrotal or transrectal ultrasonography that would, again, look for this vas deferens and see whether or not this exists or is patent there in the scrotum. And very interestingly, we really don't fully understand why the vas deferens does not develop in a man with CF. I think this is something we really are looking to understand more, but we do know that the vas deferens is very sensitive to CFTR dysfunction. And that can be seen in two different ways, and that is that there are some men out there who have 2 CFTR mutations, and their only manifestation of a feature of CF is actually absence of the vas deferens. They may have no pulmonary or pancreatic dysfunction, but they do have absence of the vas deferens. In another way, there's also been men with only 1 CFTR mutation who've been described to have congenital bilateral absence of the vas deferens. So again, this doesn't explain it, but at least tells us that this vas deferens is very sensitive to CFTR dysfunction. So as I mentioned, this absence of the vas deferens results in infertility, but certainly not sterility. So men are perfectly capable of having babies that are theirs, then fully genetically theirs, just may not always be in the natural way that they anticipated. So further, when you look at the ejaculate of men with CF, what do we know? And so we do know that men with CF have very normal sexual function, but it has been reported that the actual ejaculate may be smaller in volume. And why is that? When you look at what the composition of seminal fluid or semen is in a man with CF, there's multiple components, including the volume of secretions that come from the prostate, that come from the testes, that come from the seminal gland, through the vas deferens, et cetera. And because of this absence of the vas deferens, in men with CF, the ejaculate fluid can often largely come from just the prostate. And so the volume may be lower, but still can potentially look quite normal or sometimes just a little bit thinner. We have had anecdotal reports of men saying that CFTR modulators are increasing this ejaculate volume, and this may be due to, again, the thinning of the mucus or increased volume of secretions. So what can men do to have babies that are there genetically theirs? What are the reproductive technology options for men? So really, this requires, for those who do have absence of the vas deferens, it would require what we call microsurgical sperm extraction. And this comes in two main forms, as you see here on the right, and that is testicular sperm extraction, which we call TASA, and microsurgical testicular sperm extraction. And these are basically similarly at slightly different processes of essentially removing a small portion of tissue from the testicle. That tissue can be looked at under the microscope to recover viable sperm. And then these sperm can be, again, basically mixed with eggs from their partners or delivered directly into their partner's uterus through intrauterine insemination, or what we call intracervical insemination, where these sperm are either put right at the crest of the cervix or beyond, or again, in a petri dish for in vitro implantation later. This other method of this microsurgical TASER procedure is essentially just when this procedure is done under a microscope and allows for sperm retrieval to have a much higher probability with a much lower chance of resulting in any damage to the testicle. It tends to be a little bit more costly, but often a more successful option. So what's the potential impact of CFTR modulators on men who are planning to have children of their own? Well, it's important to understand that the general life cycle of a sperm is about 74 days. So if a man is planning pregnancy or planning sperm extraction, et cetera, if you would like no CFTR modulator impact or exposure of that sperm on the baby or on this pregnancy, then one would have to hold the modulators for almost 75 plus days. So that's important to consider. Now, do you need to? We don't necessarily know the answer to that. There really actually been no chromosomal abnormalities observed secondary to CFTR modulator exposure, but these small molecules are assumed to achieve concentration in the semen that is similar to what's in the plasma. So there can be certainly exposure of these CFTR modulators to the sperm. In addition, it's thought that the CFTR modulators, when they reach the sperm or semen, can have 100% absorption in the vagina of their partners. So something to think about, that this exposure is quite possible. And importantly, in animal studies, there's been no evidence to suggest an increased risk to the fertilized egg when exposed to CFTR modulators. And this is, again, a topic we have much to learn about in the future, but really have very little data, as a number of our databases, particularly here in the United States, do not track well the men who have babies or are planning to have babies. So what do we know about the potential of CFTR modulators to rescue fertility in men with CF? And I know you all just heard from Dr. Engelhardt just a little while ago, and I'm going to quote some of the work from his group actually on the ferret model that they have used to understand this a little bit. So when you look at some of the work they did on CF ferrets, very interestingly, they took CF ferret mothers who had the G551D mutation who were treated with ivacaftor while pregnant. So ferrets that would be G551D homozygous and responsive to ivacaftor while pregnant, they were mated with another a G551D male partner, and they looked at what did these babies look like who were homozygous for the G551D mutation. Now, this is kind of a busy picture here, but over on the left-hand side, you can see these ferret babies who were wild type, and they who had 2 wild type mutations. Now, this would not be from this particular ferret, but in general, 2 wild type ferrets that have a normal vas deferens that you can see here in this tract in these visible tubes. Then you look at CFTR dual knockout ferret babies who have no tube in this vas deferens that you can see. You look at those that are heterozygous who are treated with no ivacaftor, again, have no vas deferens. Then you look at babies who were heterozygous and had exposure to this ivacaftor, again, no vas deferens. And then over here, you look at the ones that were homozygous to G551D, but not treated with ivacaftor, again, no vas deferens. And it is not until you see those babies that were G551D homozygous, whose mothers were treated with ivacaftor throughout their pregnancy, where they did show a presence of this vas deferens. So what does this suggest? Very fascinatingly, it suggests that in a baby male ferret who's homozygous for the G551D mutation, whose mother was exposed to ivacaftor throughout that pregnancy, that there may be ability to rescue this vas deferens in these babies. And I think as Dr. Engelhardt described, there's a number of other impacts that are fascinating about the pancreas, et cetera, that we're going to learn more about as well. Now, in humans, we don't yet have any data related to this. We don't necessarily think that, in fact, we don't believe yet or have any evidence to suggest that in an already born male with CF, that use of a highly effective modulator is going to change that absence of the vas deferens in any way. And we don't yet have any reports of baby males who are born with 2 homozygous mutations, whose mother used a highly effective modulator therapy during pregnancy to know what's going to occur. There was a recent report out of New York of a baby female who had homozygous mutations, whose mother took highly effective modulator during pregnancy, and that baby was actually missed on newborn screening because of pancreatic function, but we do not yet have a baby male to know what might happen to the vas deferens. But I think this is a fascinating question that we're waiting to learn more about in the future. So moving a little bit into contraception. So when you look at contraceptive use in women with CF, there's been some data out there, and actually this was a paper published by Emily Godfrey and a number of other CF researchers that did a survey of 150 women with CF ages 18 to 50 who were being seen at 3 different US CF centers. They looked at what were the most commonly used contraceptive therapies these people took. And overall, combined hormonal contraception, meaning a combination of a type of estrogen and progestin, was the most commonly used type. And this is what's seen in the general population as well, but there was a number of other forms, including barrier methods and long-acting reversible contraceptives that were used as well. When you look at what do we know about these contraceptives and their interaction with CFTR modulators, it's important to understand that most hormonal contraceptives include ethinyl estradiol and progestins, and that these are metabolized by CYP3A, which is a pathway that is many drugs go through in their metabolism. It's also important to understand that ivacaftor, tezacaftor, and elexacaftor are CYP3A substrates, but yet in drug-drug interaction studies have shown no interaction with hormone contraception. So hormone contraception is thought to be efficacious and safe when using these 3 types of modulators. But when you look at lumacaftor, not only is it what we call a CYP3A substrate, but it's also an inducer, meaning it can promote metabolism or increase metabolism of these hormone contraceptives and therefore decrease the exposure in the woman and make them potentially less effective. So if somebody is on lumacaftor, meaning ivacaftor, lumacaftor, or can be, it's important to warn that woman that hormonal contraception may not be an effective mode of contraception and that a second form of barrier contraception or something else should be used if not intending to get pregnant. I'd also importantly want to mention contraceptive use in men with CF, and that is because it is still very important. As I mentioned, not all men with CF are infertile. You cannot know that unless tested. So barrier contraception in particular, condoms, are still very important to minimize potentially sexually transmitted infections. So I think this is something in CF clinic we don't counsel enough on, but is still a very important topic. So finally, I'm going to move into pregnancies in women with CF. And you can see that this is data taken from the CF Foundation annual registry report, and the latest data being from 2019. And you can already see visually that we've seen a rise in pregnancies in women with CF. And I'll tell you, I think as we see 2020 data, we're going to see the rise be even greater. Many have termed this the Trikafta baby boom, which we're experiencing here in the United States since the release of Trikafta at the end of 2019, which I think is wonderful news for many. But what do we know about pregnancies in these women with CF? So first of all, when you look at outcomes, there's been a couple of large registry analyses looking at a comparison of women pregnant with CF versus those who did not become pregnant with CF. And you can see here on the right, this is what we call a survival curve, meaning the comparison of the life expectancy of a woman with CF who chose to become pregnant versus those who never became pregnant. And actually, there is no survival disadvantage in a woman who chose to become pregnant in this study. But importantly, and it actually looks like a trend of these pregnant women did better. But it's important to understand that these women who became pregnant were actually generally healthier at baseline. So it's a little difficult to compare this head to head. In other analyses that have been done using large databases, including the CF epidemiologic database, when you look at this data, pregnant women that made up over 100 of the women in this database actually did have more illness-related visits. They had more pulmonary exacerbations, and they did report lower quality of life scores in this database. But importantly, they did not have an accelerated rate of disease progression or an increase in mortality noted in this database. So good news overall. You do have to look at the complications that occur in mothers and in their babies when it comes to women who become pregnant with CF. And when you look at the maternal complications reported out of a number of different databases out there, that there is actually a higher rate of gestational diabetes reported in women with CF than the general population. There's also a higher rate of infection, higher rate of preterm labor, and a higher rate of gestational hypertension and preeclampsia. Now, this data was taken pre-highly effective modulator therapy, but important to understand nonetheless. When you look at infant complications of those born to mothers with CF, there is a reported increased rate of congenital abnormalities, an increased rate of newborn jaundice, increased rate of C-section deliveries, and an increased rate of prematurity. But again, this was not data that was followed prospectively. We do not necessarily understand all the confounders that might have been in these data sets, and again, what the impact of highly effective modulators are on these outcomes. There also have been studies to suggest that low lung function, particularly in FEV1 less than 50% in a mother with CF, can be associated with a decrease in gestational age or preterm delivery and decreased birth weight in these babies. So very important to think about baseline health status before planning a pregnancy and cystic fibrosis, and talk with your CF care team and with your maternal fetal medicine team. So I do want to mention pregnancy in a woman who has undergone a lung transplant in CF. And this is a topic where there is very little data, but I do want to mention the maternal and fetal complications can be quite high. In some national transplant pregnancy registry data analyses, which are very small databases, there was 30 pregnancies reported. 12 of these women actually had CF. Many, or a high number, experienced preterm birth. 11 had infant complications, including low birth weight, and there was actually 2 neonatal deaths. In addition, the rate of lung transplant rejection was quite high, and in this population, 25% of these women were women with CF. Now, this is not quite understood why, but often what occurs is because the impact of immunosuppressives on the baby is not well understood, the care team will try to decrease the immunosuppressive medications as much as possible, which can result in potentially increased risk of rejection. In addition, there's question of whether during the pregnancy, cells from the infant can pass through the placenta, impact the mother, and also result in an increased potential for rejection. There are also a few of the classic immunosuppressive medications, including a category called mTOR inhibitors, the most common one being sirolimus, and anti-proliferative agents, the most common one being mycophenolate mofetil, which have been in animal studies reported to be potentially teratogenic. Now, we don't understand or have much data in humans at all, but these are important things to consider. So if you've undergone a lung transplant or you have a family member that has and are considering pregnancy, you really need to talk to your transplant team. Some transplant centers would advise avoiding pregnancy altogether, and some would say to wait at least 2 years after that transplant so that to become pregnant, so that you're on the lowest possible dose of immunosuppressive medications before going into that pregnancy. So when you look at medications in general in pregnancy, there's a lack of literature, not just in CF, but throughout medicine. And much of this is women who are becoming pregnant or who plan pregnancy are not included in phase 3 trials of drugs, understandably. So there's a lot of things to consider on weighing the benefits and risks of continuing medications versus stopping them when you're planning a pregnancy. Things to consider include the timing of these medications in pregnancy, whether it's going to be in the first trimester versus third, et cetera, whether these medications are going to be administered IV versus oral versus inhaled. Many of the inhaled medications are not absorbed to the same extent, and what the health is of mom pre and post this medication. So when you look at the impact of CFTR modulators in particular in pregnancy, which is I think a question that many are asking right now, there's very little data available, but there is some, and there is a plan for more data. But again, you have to weigh the risks and benefits. So there's actually been some reports out there, not necessarily in women planning pregnancy, but this was a report out of the North Carolina group by Aaron Trimble and Scott Donaldson that showed that in some of their patients who actually had stopped ivacaftor, that they actually had a decline in their health by FEV1 in 3 cases, and one of these people even passed away when their ivacaftor was stopped completely. So one has to think about this. In another abstract that was presented, in patients who are on a trial of a phase 2 trial of highly effective modulator therapy, who stopped the highly effective modulator therapy, there was a lung function decline in 7 out of 10 of these, and 5 of these people experienced pulmonary exacerbations. So I'm not going to go into this in detail, but I'll just let you know there's 2 reports out there, one by Nash and colleagues published in the Journal of CF, and one by myself and Jennifer Taylor-Kauser published in the Journal of CF also in the past year, describing some of the data that CF physicians have reported in their women who've been on ivacaftor, Lumivy, or Tezaiva during pregnancy, or most recently on ETI or Trikafta during pregnancy. And I'll tell you, just to summarize this so I don't go through all of the numbers here, that overall, the good thing is that the maternal complications have been quite low and not necessarily deemed related to CFTR modulator therapy, and that the miscarriage rate for women in CF on these modulator therapies also quite low as 5%, and it's really thought to be about 15% in the general population, and that there's really not been complications that are just in infants directly exposed to highly effective modulator therapy in utero that have been deemed related to this therapy. In this second study that I talked about with Trikafta, there is actually in this report 47 women who had pregnancies were exposed to Trikafta at some point during their pregnancy, 2 that were just exposed during lactation. And again, the miscarriage rate was low, the complications in mom and in babies, again, quite low. So I'm not going to go through all these numbers just for the sake of time, but I'll put it up there. But I do want to highlight that the other thing that came out of this is in a few of the mothers, 5 out of 6 of the mothers who had their modulators stopped during their pregnancy, a number of them had to resume therapy because of decline in their health once they stopped this highly effective modulator therapy. So this really, again, points to the balance that one has to go through themselves with their care team and with the maternal fetal medicine or OB-GYN team when thinking about the choices of what you're going to stay on versus what you're going to discontinue going into a pregnancy. I do want to point out that many have asked about whether CFTR modulator therapies are present in breast milk. And there was actually a nice study that was published again by Erin Trimble at the University of North Carolina when it comes to lumacaftor, ivacaftor. And indeed, both lumacaftor and ivacaftor are found in breast milk. And I think we'll find an upcoming report that it's actually true for elexacaftor, tezacaftor, ivacaftor, and can be found in infants who are breastfed, though at an exponentially lower level than what's found in the serum of mother. So there is an exposure. In addition, in animal studies, particularly in rats, there was a report of those that were exposed to ivacaftor of an incidence of cataracts in these rats that was seen. And as well, there has been some reports of elevated LFTs in this infant in particular in this report in a mother who was treated with lumacaftor, ivacaftor during breastfeeding. Now, whether or not that's related to the Lumiva, no one knows. But as a result, many physicians are recommending that if a woman chooses to stay on their highly effective modulator therapy during breastfeeding or in utero, that one should consider having this baby assessed for cataracts and following liver function testing in the baby after delivery and throughout breastfeeding. So I'm just going to move ahead and mention to you that there is an upcoming study called the Mayflower Study that's sponsored by the CF Foundation that is going to look at pregnancies in women prospectively and really follow not just those on highly effective modulators, but in all women, and understand the impact of pregnancy on lung function, on pulmonary exacerbations, on nutrition, on glucose control. A big component of this is going to be looking at the impact of glucose and by continuous glucose monitoring, as well as the pharmacokinetics of modulators in the mother, in breast milk, and in the infants over time. So we're very excited that the study is going to start in the next few months and are hoping we can gain even more information about pregnancy for people who are thinking about it, and particularly women with cystic fibrosis. So this is just highlighting some of the upcoming, as you can see, there's a huge amount of upcoming studies, that are going to be related to reproductive health in the world of CF. And as I mentioned, there's a host of questions we still have, but as you can see, we're starting to look at things including fertility, contraception, urinary incontinence, which I didn't even touch on, how we talk about infertility in men and women with CF in clinic, and even the impact of parenthood on people with CF. So I think it's a really exciting time for a topic we haven't hit on much. And I do also want to end with saying that I really frame this talk today talking about sex and gender as a very binary topic. I understand that gender is not binary at all, and that there is also much to be learned about gender affirming therapies and gender transition on the health of someone with cystic fibrosis. We're excited that there's actually going to be a talk this year at the National CF Conference about gender diversity and trying to understand the impact of things such as chest binding and hormone therapy and how this may affect someone with cystic fibrosis. So I didn't want to not mention that topic as well. So I'll just end by saying our work has just begun. We have much to learn about the impact of sex hormones, fertility, contraception, pregnancy, and a number of other topics, including urinary incontinence and menopause on people with CF, particularly in this new era of highly effective modulator therapies. But I think in the next several years, we'll see a huge amount of data coming out so that we can have much more informed discussions for all of you and for your families. So I'd just like to end by thanking you all for the invitation to speak today. This has been a really tremendous conference, and I know I've learned so much. I absolutely want to thank the people with CF that I take care of who gave me the permission to show these pictures today, as they really inspire me every day, as well as our Women's Health Research Working Group through the TDN, who I've really enjoyed working with on a number of these topics, our care team at UT Southwestern, as well as our research team, and the CF Foundation, who sponsored a number of the studies that I described today. And with that, I'll be happy to answer any questions.
Thank you so much, Dr. Jain, for that incredible, very rich, very full presentation. And I apologize to everyone because we actually, the next session, we bumped it 5 minutes, but the body image session will start in 5 minutes. So Dr. Jain, are you willing to just rapid fire 1 or 2 questions? And then either 2 things, maybe you and I could Zoom after the conference and we can run through all the questions in the chat box and record it and post it as a video for people so that every single question is addressed, because there are so many fantastic questions.
Absolutely. I'm so sorry I ran a little bit over.
No, there's so much to talk about and not enough time. So, but question, are there studies regarding irregular menstrual cycles for assigned females at birth, people with CF?
So studies about whether they have irregular menstrual cycles. So that's a great question. So far, there are not any prospective studies of that. There have been some very small studies understanding, do women as a whole with cystic fibrosis have irregular menstrual cycles? And the thought overall is that if nutritional status and health is in a stable state, that they have potential to have very regular menstrual cycles. But there are, of course, women who report irregularity, and that can be due. This is something that occurs in the general population as well and is not necessarily related to their CF. But if health is in a state where someone is getting sick frequently, if their nutritional status is low, then there's definitely been reports of irregular menstrual cycles.
And one last question, has there been, in regards to men with CF, with CBAVD, what about intracytoplasmic sperm injection? To my knowledge, this has the highest success rate for fertilizing the woman's egg.
Yes, and so that's correct. So for men with cystic fibrosis, as I mentioned, that for those who are infertile, the sperm can be retrieved through a surgical technique, and this can absolutely be implanted directly into the uterus of their partner, typically past the cervix or even right at the cervix, and they can their spouses, their partners, etc., can have a very natural pregnancy. And the timing of that introduction of the sperm is critical so that it fertilizes the eggs. But many men with cystic fibrosis have had babies that are genetically and very naturally theirs, but the sperm just has to be implanted into their spouses or partners.
So with this, you and I, if I can impose on you, are going to connect right after this conference to have a date in the immediate future to do a quick Zoom, answer this list of questions I promise everyone, and we will release and announce and people can log in and watch. So with that, I thank you so very much for sharing your time, your incredible expertise on such an important topic, especially now. It sounds like there's a baby boom going on out there due to the modulators. So thank you very much. And I look forward to seeing everyone in literally 2 minutes over at the body image panel. So thank you again, Dr. Jain.
My pleasure. Thank you.